Okay, folks, we're going to go ahead and get started. I wanted to welcome you to today's webinar, What We Know and What We Want to Know Regarding Co-Occurring Disorders. This is going to be a conversation for figuring out real needs. I want to welcome you on behalf of the Pacific Southwest Mental Health Technology Transfer Center. I wanted to let you know that we are part of a network of technology transfer centers. We are in the Pacific Southwest serving Arizona, California, Hawaii, Nevada, and all of the U.S. Pacific Island jurisdictions. So if you would like more information, you'll have contact for all of the networks at the end of this session. We are able to provide this session at no cost, along with many other learning opportunities because of SAMHSA's sponsorship for this initiative. We are a regional center designed to bring professional development opportunities, learning opportunities, and capacity building to the mental health workforce. And we are providing that through a number of different modalities. You can see some of them here in terms of our distance learning. We also have newsletter resources available on our website. And we're also providing face-to-face or on-site learning opportunities, including a summer institute in Sacramento this June. If you'd like more information about the trainings that we'll be providing at no cost, there is an announcement through our newsletter and also on our website. And as I mentioned, the contact information for our center will appear at the end of today's session. So again, thanks for joining us today. And I wanted to take a minute just to introduce you to our team today. So my name is Dr. Christina Borbet, and I'm the co-project director for the Pacific Southwest Mental Health Technology Transfer Center. And I'm really excited to be facilitating for you today, and I am joined by my colleague, Dr. Heather Gotham. And Heather is at Stanford University School of Medicine, and she is the director for the MHTTC Network Coordinating Office. So thanks for being with us here today, Heather. I'm going to pass it off to Heather in just a few minutes, but I did want to make sure to orient folks to what we are doing here today. We have designed today's webinar to be an interactive session. We really want to make sure that we are leveraging all of the expertise on the phone, and so we wanted to organize this as a peer discussion panel. And while we certainly do have the benefit of Heather's expertise on the topic of co-occurring disorders, and we can spend some time talking about that, we also wanted to make sure that you were positioned to share your questions, your input and experiences, as well as exchange resources in terms of what's working for you in serving this population. So be prepared. We're hoping that you're going to contribute today, and we have a small group, so that should make it a really meaningful exchange. And I'm going to ask a couple of questions just to kind of get the ball rolling. For those of you who are joining on our Adobe Connect platform, if you could please go ahead and use the chat box to share some information about what your role is or what work you're involved in when it comes to populations experiencing co-occurring disorder, just so that folks can get a sense of who their colleagues are on the line. If folks could go ahead and put that in, that would be really helpful. I wanted to just get a sense of, as you're kind of coming to this conversation, what it is you're hoping to get out of the conversation today. So I'm really curious in terms of when you're thinking about serving this population, what you see as your biggest challenges, and then also just curious about what it is that you would most like to know from your peers with regard to addressing co-occurring disorders. So why don't we start with biggest challenges? Is there anybody on the line who'd like to introduce themselves and talk about what challenges they're facing? So as we're moving through the content today, Heather and I are both positioned to kind of voice what we've heard. We've been getting input and requests for information about and opportunities to discuss co-occurring disorder, and so we're happy to kind of represent those voices. But again, we do really want to make this as interactive as possible. So just to kind of set expectations as we're moving forward through the content, what I think we'd like to do today is just spend some time walking through an overview of what we're talking about when we're talking about co-occurring disorders. But we also want to make sure that we have time for discussion to really talk through how we're defining what the need is. So oftentimes what Heather and I are hearing from the field are these needs for more training, for more support, for consultation around co-occurring disorder. But that's a pretty broad stroke request. And so part of what we want to do today is really unpack what is the problem that we're trying to address. And that kind of helps us determine what are the resources or what are the professional development opportunities that are most appropriate to meet that need. We also wanted to spend some time in discussion thinking about how we can address these different needs. So when it comes to co-occurring disorder, a lot of times we're thinking about things through a practitioner lens, but we also, in addition to thinking about practices, wanted to talk through what we know and what we would like to know in terms of policies and research that contribute to our work serving co-occurring disorder populations. Before we end today, we'll definitely have opportunity to talk through what it is would be most useful for you all in terms of providing professional development or learning opportunities on this topic. So as I mentioned, we're able to design a range of learning modalities through the Pacific Southwest Mental Health Technology Transfer Center and make those available to the field at no cost. And we want to do that responsibly. And so part of what we'll be doing today is making sure to get your input on what more, what else is going to help you make sure that you're addressing the needs that you have on this particular topic. All right then, Heather, I'm going to go ahead and turn it over to you.
Thank you very much, Christina. I appreciate your introduction as well. I'm Heather Gotham with the MHTTC Network Coordinating Office, but also wearing my hat here at Stanford University School of Medicine as a clinical associate professor. And wanted to acknowledge my co-authors on this presentation, Merit Asifa, as well as Mark McGovern, who is a long-time outstanding person in the field of co-occurring disorders and who I've had the pleasure of working with and collaborating on co-occurring disorders specifically for the past 15 years. So I'm just going to try to set the stage a little bit and give an outline of some of the issues related to co-occurring disorders, including treatment options, the current state of access to integrated services, at least as it is across the country. Talk a little bit about an implementation gap and what we can do to better understand what services are being provided, as well as how to increase the implementation of integrated services. So at any point, if people have comments or questions, please go ahead and chime in. Just to start off, so we're all on the same page about co-occurring disorders, of course, we're talking about co-occurring disorders as referring to the coexistence of both a substance use and a mental health disorder. And we know that co-occurring disorders are highly prevalent. They often begin in youth. And really, I think as we think about kind of mental health disorders and substance use disorders, we can think about the occurrence of mental health disorders. We're learning more and more every day about how they have their roots in adolescence and sometimes in childhood. There's more of a focus nationally on things like first episode psychosis or clinical risk for psychosis. And we know that that is often co-occurring with substance use disorders. We certainly understand substance use disorders more now to be disorders of adolescence and disorders of young adulthood. So I think we're doing a better job of understanding those roots of both mental health and substance use disorders as being earlier and earlier these days. And we also know that folks with co-occurring disorders, often there's significant burden on patients and on families and on society. And if untreated, patients with co-occurring disorders can face problems not only related to their physical health and their mental health and their other health, but also other aspects of their lives, including school and work, relationships, housing, economics, and incarceration. We're also understanding more with recent research on increased risk for suicide in people with co-occurring disorders. So just a couple slides looking at the overall picture in the United States. So we know there are about 46.6 million adults with mental illness and about 18.7 million adults with substance use disorders, and right there in the middle are 8.5 million adults with a substance use disorder and a mental illness. In terms of treatment options, we know that co-occurring disorders are common. They're common in general medical settings and in community samples, but they're endemic. They are to be expected, not the exception, in specialty behavioral health care settings, criminal justice systems, and among the homeless. We also know that treatment for co-occurring disorders is really offered in diverse settings. So it's not just in the behavioral health care setting or in the mental health setting, but it's offered in a range of settings. And depending on where patients seek treatment, substance use disorders can be provided by different types of providers, by mental health providers, by substance use providers, by primary care providers, and people experience different treatment approaches. This slide shows a little bit about the kinds of services that people with co-occurring disorders receive. So again, looking at that 8.5 million adults who have a co-occurring disorders, do they receive treatment? What treatment do they receive? This is from the National Survey on Drug Use and Health, and we see that almost half of people with co-occurring disorders don't receive any treatment in the United States. of those who do receive treatment, most of that treatment is for mental health services only. So the substance use disorder is either going unrecognized or untreated. There are a few people who receive treatment for substance use only, and then about 8% who really receive mental health services and specialty substance use disorder treatment services. So it's that 8.3 that we're looking at who really receive treatment for both, which is pretty alarming that given the state of our healthcare system, those are the only folks who are receiving services for both disorders. So that's where we want to start talking about integrated treatment services, which really address both problems, the substance use and the mental health problem at the same time, during the same treatment episode by the same providers. So that is the definition of integrated services. They're not co-located, but they're really integrated and being provided at the same time by the same team. And that's our gold standard. Integrated treatment can be seen through stages. So this slide is from integrated dual disorders treatment, which is an evidence-based practice for co-occurring disorders. And it shows that through this lens of integrated treatment that you can think about the stages of change as also referring to stages of treatment. And depending on what stage of treatment or stage of change someone's in with relation to their co-occurring disorders, you might be looking at different problems, different aspects of the co-occurring disorders. You'll be targeting different behaviors, and the interventions will be different. So I think this is really an elegant and kind of hybrid model where we really take into account where the patient's at in terms of their co-occurring disorders. So for example, if they're in the engagement stage, then the problem that we're looking at is really the lack of regular contact with the treatment program. So if someone's in the engagement or the pre-contemplation stage, really trying to consider whether or not they have substance use disorder and mental health disorder, or whether or not they want to engage in services, we're not starting right there with jumping in and dealing with treating their co-occurring disorders. We're really looking at and recognizing that the problem that we're focusing on is lack of contact with the treatment program. And so the targeted behavior that we'd be after at that point, looking at with the client or the patient, is how can we get the client or the patient to have regular contact with the treatment specialist? And then the interventions that flow from that are going to be things like assertive outreach, practical assistance, really, again, meeting the patient where they're at. Maybe they're not ready to be in a full treatment program, but they need practical assistance with housing, healthcare. And we're going to look at the intervention services we're going to provide are really about introduction to treatment formats. So introducing them to individual treatment or family treatment or group treatment. When someone is in a further stage of change related to their disorders and also related to their treatment, then we can really start looking more at the actual clinical issues. So you'll see here that, again, depending on the stage of treatment, that's going to reflect what the intervention is. It's only when someone's in active treatment, for example, that we're really looking at achieving abstinence or managing their substance use and mental health disorders, teaching and practicing coping skills. And that's when we're going to be using what we might traditionally think of as the evidence-based practices, things like cognitive behavioral counseling and other supports like that. And I also think it's important that this model focuses on relapse prevention or maintenance as a stage in and of itself, and that there are specific interventions that are different, but that go along with that. So for example, here's where self-help groups are going to have the most impact. Self-help groups are very important, and for some people an essential component of their recovery and of their sobriety and staying off of drugs. But it often is only when people are in that relapse prevention or active treatment phase when the self-help groups are most important. And I think there's many times when we throw referrals to self-help groups at people too early in the process, and therefore can really lose that engagement piece with them. Research has shown that co-occurring disorder patients have poorer outcomes when they are treated in this kind of single disorder treatment or non-integrated system of care. And unfortunately, for so many years, that's been the way the American treatment system has worked. We have siloed our substance use disorder treatment and our mental health treatment into totally separate systems, separate payment, separate, we're funded by SAMHSA, and SAMHSA is separate. We have the Center for Mental Health Services, we have the Center for Substance Abuse Treatment, they're separate. The block grants are separate, right? It's all separate when what we really know is that these co-occurring disorders co-occur, right? And they are very prevalent. And the most effective treatment is integrated. So research evidence really supports the effectiveness and the economic viability of integrated care versus targeting one or the other disorder independently.
Hey, Heather, would it be,
Yeah.
I wonder if I could just insert a question about that, because I think it comes up so often, is how do we deal with siloed systems? And so when you were sharing the previous slide that kind of showed what does the integrated treatment look like, is that approach appropriate, or is that design appropriate to be implemented in either setting, so in a mental health treatment setting or a substance use disorder treatment setting?
Yes, and I think there really are models of treatment now and enough flexibility in most state systems to provide some level of integrated treatment across a number of settings. So what we're going to see a little bit later in the presentation is that not every addiction or mental health treatment program needs to be fully integrated, right? That may be a bridge too far at this point, but there are certainly in most jurisdictions the ability to pull together an integrated treatment program that works through both silos and provides this level of care.
Okay, that's helpful. So obviously fully integrated funding streams are the gold standard along with these stages of integrated treatment, but in terms of real world applications, that there's other versions of it that can leverage the effectiveness of the integrated treatment model.
I think so, and also some of it has to do with the level of acuity and severity of the disorder. So if you have someone with a severe substance use disorder but a fairly low level mental health disorder, they might not need a fully integrated treatment program, or that might not be necessarily the best level of care for them. But if you have someone with a severe substance use disorder, long-term substance use disorder and a severe mental health disorder, then this level of integrated treatment is most likely going to be the most effective. So that's
helpful context.
Another consideration.
Thank you.
So interestingly, the next couple slides look at what are people's preferences. So here's a study of clinician preferences and clinicians who treat patients with dual diagnosis, another name for co-occurring disorders. We've found that clinicians perceived greater difficulty with treating dual diagnosis versus a single disorder. So yes, it's more difficult to treat patients who have both disorders, yet the gratification was higher for treating patients with both disorders. And gratification was rated higher than difficulty. So I think this is a great quote. As difficult as it is, this thing about treating dual diagnosis work pushes me to find new aspects of my own humanity, to honor that, and then to turn it around and use it to help my clients. They are my teachers. There have been a number of studies that have also looked at patient preferences related to integrated treatment versus singular disorder treatment. And most clients with co-occurring disorders reported treatment satisfaction regardless of study location, treatment setting, and treatment type. I think this is a finding kind of across the patient preference or patient satisfaction field, regardless of what disorder you're looking at. But we do find that in some of the studies that patients rate integrated treatment with higher satisfaction than single disorder treatment. So I want to talk a bit about access to integrated services and what's that like. So as we said before, of the millions of Americans who have co-occurring disorders, it's only less than 10% receive proper treatment, less than 10% receive treatment for both their mental health and substance use disorder. And this shows a number of barriers to integrated services. Certainly things that we were talking about before related to the way the system is set up to be siloed. There are policy barriers related to organizational structure and financing and regulations and licensing. There are barriers at the program level in terms of what service models are being used, contractual incentives, outcome measures that don't measure both disorders, personnel, and other resources. There's clinical barriers or barriers at the clinician level in terms of their knowledge and beliefs. We have really separate systems for growing up behavioral healthcare professionals. There's the addiction counselor track, which is really separate in most places from the more traditional mental health disorder professional tracks like social workers, psychologists, even physicians and psychiatrists, and that all of us, putting myself in that psychologist category, receive really very little training on addiction. And so there are barriers both ways, that substance use disorder counselors don't necessarily have a good background on mental health disorders. And consumer and family barriers as well, in terms of, I think, a lack of understanding of consumers and families about co-occurring disorders, denial or minimization of one or both disorders, and patients unfortunately feeling like they don't have a lot of self-efficacy to choose treatment programs to be able to access treatment or to advocate for themselves at time for what the best treatment might be for each of them. So unfortunately, what we have here is an implementation gap, one way to describe it. So an implementation gap occurs when you have an effective intervention, like integrated treatment, but you have what we call ineffective or insufficient implementation, where that intervention isn't being implemented, isn't being put into clinical care, isn't being used, isn't being effectively integrated into a treatment system. So insufficient implementation. And that means that our patients unfortunately end up with poorer outcomes, and people find that treatment programs aren't sustainable or the effects that they get are inconsistent. So this is an implementation gap, we call this. We have that related to co-occurring disorder services, especially related to integrated services. So one issue I think is that when you talk about integrated services and you just say, oh, do you have integrated services? Do you provide services for people with both substance use and mental health disorders? That most people are going to say yes, because that term integrated can lack specificity without having any objective criteria. The chart here shows the results of self versus independent ratings of a treatment program's capability to provide co-occurring disorder treatment. So does a treatment program provide services at the integrated level or at a level lower than that, where they're really providing services for one disorder or the other? And what we see here is, this is a study conducted in Australia, and what we see here is that at baseline, the programs rated themselves on a scale from 1 to 5, they rated themselves at an average of 3.4. So that's how, with a higher score, meaning that the program was more integrated, provided integrated care. So self-rating, yep, we're above average, 3.4. We provide co-occurring services. And yet when independent ratings were made of that same treatment program, they were rated at about 2.5, so about a point difference. And at follow-up, about a year later, the same programs rated themselves and then were also rated by independent raters. And we see that the programs rated themselves as having gotten better. We are even more integrated than we were before. Now we're at a 4 on a scale from 1 to 5. But the independent ratings showed that they had not changed. This is a typical kind of self versus independent rating. We all rate ourselves above average, right? We're all above average. We all do really well. But I think it's an example of how we need some objective criteria about what integrated treatment means, and also can use independent ratings. And so, like other evidence-based practices, integrated treatment can be assessed using a fidelity type scale. What I want to talk about next is a way to get at that implementation gap. How can we measure co-occurring disorder organizational capability, or the extent to which a treatment program provides integrated services? And what really are those core clinical components of integrated care? There are a number of ways to measure co-occurring disorder capability, or the extent to which a treatment program has provided integrated care. I'm going to talk about these 3 that I've had the pleasure of working on for the past 15 years. So the dual diagnosis capability in addiction treatment, called the DD-CAT. There is a similar index for mental health treatment, which we affectionately call the DD-MUT. And then there is the behavioral health integration in medical care. So the DD-CAT is a measure that if you have an addiction treatment program and they're trying to integrate mental health services, then the DD-CAT is the appropriate measure. If you have a mental health treatment program and you want to look at the extent to which they have integrated addiction treatment, then that's the appropriate measure. And then the behavioral health integration in medical care measure is used for primary care or other medical settings that are trying to integrate behavioral health services into the services that they provide. So DD-CAT, DD-MUT, and both of these indices are quite similar. They each have 35 benchmark items and 7 dimensions. Here are the dimensions. So each of these tools looks at things like program structure. What's the mission of your treatment program? What's the structure and financing? What's the format for delivery of substance abuse or mental health services? It looks at the program milieu. So what's the physical, social, cultural environment for persons with co-occurring disorders? Does it feel welcoming? Do you have patient education materials about both disorders, or is it all focused on one disorder? It looks at the assessment process. Do you provide screening and assessment and diagnosis for both mental health and substance use disorders? The treatment dimension looks at what are the evidence-based practices that are being used specifically for mental health and substance use disorders. Do you really provide treatments for both? Under continuity of care, that looks at what does the discharge process look like, or the ability of the program to provide services kind of over time for both addiction and mental health disorders. Are there peer recovery supports provided by the program? Staffing looks at the presence and the role of staff, the integration of staff with addiction treatment expertise or mental health expertise, and whether or not there's supervision for both disorders. And then training looks at, are your staff trained in co-occurring disorders? Are they cross-trained? Is training on co-occurring disorders part of the new employee onboarding process? Each of the items is scored on a range from 1 to 5, as I said, so that'd be 1 would be like addiction or mental health only services. 3, kind of in the middle, looks at dual diagnosis capable. So that means that you're able to provide services for clients with low severity co-occurring disorders. And then dual diagnosis enhanced or fully integrated is that you're able to serve clients with more severe unstable co-occurring disorders. So that's what I was talking a little bit about before Christina asked the question, is that perhaps not every treatment program needs to be at a dual diagnosis enhanced level, but can we look at programs across the range, and in any particular geographic area, for example, are there dual diagnosis enhanced programs that patients can go to, and kind of what's the case mix there? This is an example of the summary profile that one would get from using one of these tools. So a treatment program really gets to see kind of where they're at in terms of each of the 7 dimensions. So this is a real-world example of a treatment program in Washington State. And you can see that in one treatment program, you can be a little bit all over the map in terms of the services you're providing. So maybe you do really well, as this program did, in terms of staffing, but maybe your clinical treatment, or in this case, the continuity of care, or those dimensions, your program is closer to a dual diagnosis capable level. These tools can be really helpful in a number of different ways. I have worked with treatment agencies, with treatment systems, with states, with regions to use these methods, looking at baseline and then as a measure of change over time. Single agencies can use them as part of a quality improvement process. You can use them with a formal implementation and change plan and that kind of development process. They've been used for large-scale system change, and they've been used in formal implementation science and health services research studies. There are pretty substantial toolkits for the DD-CAT and the DD-MUT, and they are available here at this address. And the toolkits go in depth in terms of really helping someone understand how to use the scale, how to interpret the results, and really understand the process.
So Heather, can I ask a couple questions about that?
Sure.
So in terms of the toolkit, does that really position an agency to be able to implement these measures so if they can self-administer, or are they available at no cost, or do they need to then engage services to be able to administer and interpret the findings?
So these tools are definitely free. They're in the public domain, so they're able to be used. And I think that kind of my line on whether or not to have objective raters is, if you can go into it as a treatment agency with an eye towards saying, we really want to be objective, we're going to study up on how to use the tool, really look at the criteria, and try not to overrate ourselves, which I think just humans find difficult, but I think it can be done. So if you really approach it with an eye toward, we really want to know, rate ourselves objectively, how are we doing? And we're going to use this as part of an implementation or a change plan, then agencies have had great luck doing that. And I really think it's beneficial. Or if they want something more objective or, want to seek assistance, then they can certainly seek assistance. There are a number of folks across the country who've been trained in these tools. But I do think that agencies can and should use them themselves as part of their change process.
And so strictly just for the assessment portion of things, so what would you say in terms of timeline to allocate? I mean, I know there's a whole change plan that you would implement subsequent to getting the results, but in terms of doing the assessment itself, what's the timeline look like for that?
Sure. So, and this is all outlined in great detail in the toolkit to make it really user-friendly, but typically if I'm like the observer who's going to go into an agency, I'll plan a half-day visit, and that visit will include a tour of the agency, a brief interview with the program director. So Mark McGovern, who fathered these measures, says the more time you spend with the program director, the less objective your results are going to be, right? Because you really need to talk to the people who are doing the work. So interviews with frontline clinicians, and there are, in the toolkit, there are a list of questions to use with the frontline clinicians to ask them questions about the services they're providing so that you're able to do the ratings for each of the 35 items. It's often really helpful to sit in on a group or several groups if that's part of what the treatment program provides. And then some formal or informal interviews with clients in the program, again, to find out from their experience, do they feel like they're welcomed? Do they feel like both disorders were addressed, and how well were they addressed? So that's all laid out in the toolkit. So about a half day for the visit if you're doing it that way, and I would recommend if agencies even doing it on themselves that they plan that kind of formal process. And then it takes a few hours. You want to have a team of people doing the ratings, so it takes a few hours to go through the ratings and come to consensus on what they are, but it's really a fairly user-friendly tool.
That's helpful. Thank you, Heather.
So I want to close with a few examples. Again, these tools, and there are other tools that are out there that are good as well, but these tools have been used at the organizational level, at the regional level, at the state level. Again, trying to close this gap or close this implementation gap and really move people from thinking about changing their program to actually making changes. So a few examples of how that has worked. This is one that I worked on in Missouri, where I moved from the Missouri-Kansas area about 2 years ago. And so when I was there, we were working with a large community mental health center. They provided an array of psychiatric services. They also had some substance use programming, but it was pretty separate. And they were really interested in increasing the capability of their mental health teams in particular to provide co-occurring services. So we did a year-long project with them. So they hired some staff who at the time were with the Mid-America Addiction Technology Transfer Center, so our sister network. They had a change agent. They did some implementation planning and some coaching. They got some training along the way. And here's what their change looked like using the DD-MUT tool. So what we saw is that this lower blue line shows what their baseline scores were, and then this orange line, the one on top, shows the follow-up scores. And so you can really see that they moved from a mid-level mental health only services to providing services more at that co-occurring capable level. A few of the things they did include changing their mission statement to behavioral health, displaying literature on co-occurring disorders. But more than that, what we saw was that the staff really reflected a new acceptance of co-occurring disorders. Like, oh, we really do now recognize that most of our clients have co-occurring disorders. What can we do to be welcoming? They got some more training about dealing with substance use disorders, and that really helped them the staff feel like they had more self-efficacy. They implemented a standardized screener and assessment for substance use, which is oftentimes missing from behavioral health assessments. I think often, of course, everyone asks a few questions about substance use, but in terms of really using a standardized screener where you can more easily determine whether someone is at risk for a substance use disorder, that can be really helpful. And the charting was different as well. Their treatment plans routinely and substantively addressed both disorders. So oftentimes when we go into a mental health provider who's at a lower level of capability, their treatment plans will say something about substance use, but most likely it's like remain abstinent, right? Versus having a more nuanced and specific goal that represents really where that client is at. The intake and 90-day review records recorded readiness to change or readiness for treatment for both disorders, and they added a family education group that really used a model that's out there in the field for family education, and that group really, I think, changed not just the culture of this particular program, but really across their whole agency. They saw a lot more participation in their family services. So that would be one example. Well, this is a state example. Stan Sachs and colleagues at NDRI did this great, amazing, huge process in New York State. They surveyed at baseline using the DD-CAT and the DD-MUT over 300, it was like 350 agencies. Of course, there's thousands of agencies in New York State, but to get 350 is like huge. Over about 18 months, they provided some basic training and TA services to any of the agencies that were willing to accept them, and then went back and did a follow-up. And here are the results of that. The first bars in each of the pair, the yellow ones are the baseline, and the purple ones are the second bar in each pair are the follow-up, and you can see the changes. One of the things that was really great, I think, about this project is they called it Getting to Capable. And the idea is that they felt in New York State, like their service system was going to be transformed, right? Everyone talks about transformation, service system transformation. They felt that their system would be transformed when a majority of the outpatient clinics were rated at capable or above. So again, it's not that all the agencies needed to be dual diagnosis enhanced or fully integrated treatment, but let's at least get to the capable level, right, where we can provide, we have a basic understanding of co-occurring disorders. We're able to provide good treatment to people with both disorders, but we recognize that if someone, again, is at a high acuity or severity level for both disorders, then we're going to want to have them seek fully integrated care. So they really saw some great changes over the course of this project. And then as a last example, Mark McGovern and Meredith Sifa, who here in my office, have a current grant to use what's called the NIATEX process improvement strategies to help agencies implement co-occurring disorders care. So they have a randomized study of 49 addiction treatment programs in Washington State, and they did a baseline DD-CAT and then a one-year follow-up, and during that year, half of the programs got this process improvement component that included individual coaching and peer sharing with other agencies. And what they found is that agencies with full adherence to this protocol had significantly higher co-occurring capability at one-year follow-up than the waitlist agencies, who are now in the process of getting the same NIATEX process improvement piece. And to me, what's important about this study is that it shows that there are times when you need to seek outside help, or at least have a very formal plan for process improvement, and that we all at times want to make changes in our services, but I think it can be important. Sometimes it's actually more important, I think, for higher level folks in your agency to really understand the change process and to not expect to send, you don't send clinicians to a one-day training and have them come back and think they're just going to implement this new program, right? You need a really well thought out system of process improvement or change strategies in order to make these important and sometimes really complex changes in the treatment model. And we have come to the end of my remarks. Turn it back over to Christina, and I'm happy to answer questions or have conversation about it.
So Heather, that's really, really helpful context. And before we move into the next portion of the webinar where we'll be doing a discussion panel, I did just want to make sure that folks who had joined had an opportunity to ask any follow-up questions about the different dimensions that you had covered. So I'll just pause. And so I want to just also remind folks we're not at the end of our session, but I did want to create a space in case there were any content-specific questions or conversations that folks on the line wanted to have. So we can always move back to that because Heather's sticking with us through the rest of this. So I'm going to kick us off and say that when Heather and I first started talking about this session, it was because I had come to her with some questions on behalf of a large county system within our Pacific Southwest region. And the request was around needing more training around co-occurring disorders. So a nice big broad stroke query, what can you do to help us in this area? And so when Heather and I were discussing it, we started really kind of drilling down to understand what exactly are the needs in this area. I can voice here that, a lot of what I hear from practitioners, from leadership and administrators in mental health and behavioral health service systems are sharing is around this idea of, patients having difficulty accessing services across systems, and a lot of times that does tie back to the siloed funding issues. We also hear a lot about patients just struggling in treatment in general, and there can be kind of a lot of different needs underlying that struggle. And then some of the other things, this kind of ties back to one comment that you had made, Heather, is that I hear from both mental health practitioners and substance use disorder treatment providers that they both want to know more about the other's work. And so just kind of this need or this interest for cross-training so that professionals on both sides of this patient experience really have perspective and have at least some cursory knowledge. Substance use disorder treatment providers understanding some of the basics around mental health and mental health functioning, and then vice versa, looking at mental health practitioners and making sure that they have deeper understanding of of addiction and substance use disorder treatment standards. And so those are some of the voices I've heard from the field. What are the struggles or barriers when you're thinking about the population that you serve experiencing co-occurring disorder? What are some of the needs that you see your systems facing or your clients facing that feel like they need to be addressed but maybe currently are an unmet need? So I see that Peggy is contributing some thoughts in the chat box. She's indicating that since SUDs often begin in adolescence and students may have co-occurring mental health and perhaps physical health issues, it might be useful to talk about early identification and early intervention and what integrated care might look like in child and adolescent settings like the school context.
Yeah, this is a great question and really important to think about. I think the school mental health, the issue of school mental health services is something that we have seen a huge increase in interest and funding for and really demand for on the family side in the past few years. And a lot of schools are trying to implement things like school health centers or school behavioral health centers that include mental health and substance use treatment activities or screening and assessment activities. But I think it's also happening at the grassroots level where even if you have one school counselor, they're trying to be more, do more with their little amount of time in terms of looking at screening for both substance use and mental health disorders. I've done a lot of work in the past few years on SBIRT, which is screening, brief intervention, and referral to treatment, right? It's kind of the basic, how do you screen for substance use disorders? If using a standardized screening, you're able to put someone or indicate where they are in terms of their risk level. And depending on their risk level, that'll let you know what kind of intervention they need. So if someone's at a risky or harmful level of substance use but hasn't developed a substance use disorder, then there's a brief intervention that's a structured, standardized, motivational interviewing-based conversation to have with someone about their substance use. If someone's at a level of substance use where you're thinking they have a substance use disorder, then there is a more structured process for a referral to specialty addiction treatment. So SBIRT is certainly one way that I think schools can be looking at early identification and early intervention. I have a personal example of a teenage son who has become addicted to nicotine through vaping in high school, his first year of high school, and he just received the standard protocol in our high school for kids who are caught vaping is to have a brief intervention with one of the staff, not even a behavioral health staff, but one of the staff who's been trained in that model. And I was stunned and amazed hearing my son talk about the impact that brief intervention had on him. So I know through multiple strategies, multiple ways that SBIRT type model can work in a school setting. So that would be one example. Like I said, I think it's looking at what structured services can we provide. Can we bring in behavioral health care providers from the community into the school to provide services? But it's also what other training can we provide to the staff that we have.
And it seems like that's a good segue into a new comment that's come in from Violetta about one of the barriers they're facing in Southern Oregon is the lack of clinicians trained in delivering dual diagnosis treatment. And so Heather, I wonder if you could tie that back to what you were talking about earlier in terms of the gold standard for integrated treatment models and what types of training or preparation for clinicians, for treatment staff are appropriate.
Yeah, that's a good question too. So I think that sometimes it's a matter of cross-training. So if you're a substance use disorder counselor, can you take some basic training in mental health and vice versa? So there are basic free online courses even for mental health professionals on substance use disorder services. So the technology transfer centers, we're the mental health technology transfer centers, but there's an addiction technology transfer center network. We all use the same online course platform, which is called healtheknowledge.org, and there are a plethora of free online courses there on basic substance use counseling, substance use disorder skills, including SBIRT. So that's definitely one place to get training, but there also are kind of more specialty training opportunities, things like integrated dual disorders treatment and other more specific evidence-based practices that are out there. The Ohio Center for Evidence-Based Practices, which was listed earlier on the slide where I showed how to get access to the DD-CAT and the DD-MUT, They previously had a Center of Excellence on co-occurring disorders using the integrated dual disorders treatment model, and they are, I think, a great resource for training on integrated dual disorders treatment.
That's helpful, Heather. And I'm pulling up, while we're chatting, I'm pulling up a few other resources that I'll put in the chat box. I did add that Healthy Knowledge link, and I'll add a few others. I'll go ahead and move us forward and start thinking about what do we need to do to address the needs. So we've been talking a lot from the practice perspective, and we can stay there. But I also wanted to highlight that the policies and the research in this field are other topics that we could kind of unpack in terms of what do we know and what do we want to know to address the need. But Heather, one of the conversations that we had started to have, which was interesting context for me, had to do with the research piece of things. And my understanding is a number of years ago, there had been some focus on co-occurring disorder in the research, that there hasn't been much attention to it recently. And I wondered if you could talk a little bit about, from your perspective, whether that might be changing soon and what might be some of the factors driving whether or not this is a priority for the research field.
Mm-hmm. It is really interesting. You know, unfortunately, having been around now long enough in the field, we do see things just like with hemlines and other fashion statements, bell bottoms, that come and go. And unfortunately, co-occurring disorders was the hot topic for quite a while in the early 2000s, and then has waned as other things like SBIRT, like assertive community treatment, which has also waxed and waned over time. And, you know, with the opioid epidemic, things kind of have changed. But with things now like the opioid epidemic, one of the second stage, I think, issues with that is really people starting to look at kind of other causes for people developing opioid use disorders, or again, the concomitant co-occurring mental health disorders. And so we've seen increased interest even in the past year about co-occurring disorders, and people, I think, asking for more training in it and kind of relooking at policy change. You know, there was also a wave where all the state agencies, or almost all the state agencies, ended up combining their mental health and addiction. You know, they had been siloed, and now we're going to combine, we're going to be behavioral health, and some states have continued that way. There's some who have already split again, right? So they came together and now they divorced. But we are seeing an increase in interest in this issue. I don't know that the research necessarily has kept up with it, but it's also the case that the treatments that were found to be evidence-based 10, 15 years ago now still are evidence-based. So things like integrated dual disorders treatment or integrated treatment for co-occurring disorders is how SAMHSA have branded integrated dual disorders treatment. Those things are still effective and still helpful. In terms of practices and policies, I just wanted to say that the toolkits for the DD-CAT and the DD-MUD, at the end of each toolkit, have sections where they show folks, they give examples for each of the 35 items of, you know, if my program is at the dual diagnosis capable level and I want to get to the integrated level, what changes would I need to make related to this specific item on the survey? So I think that's a great way for people to be able to get ideas about what are practice changes that are realistic that we could actually engage in. And the same goes for policies. So there's some references in that to policy changes that can be enacted as well.
Yeah, and I definitely think the policies have been slow but are critical, again, for really breaking down or creating more space in those funding silos for created blended or braided opportunities to offer services.
I wonder if things like, you know, having the block grant applications be integrated, if that kind of change, which has just happened in the past few years, we're going to be seeing, I would hope we're going to be seeing kind of ripple effects out from that over the next few years in terms of how systems are changing. That might be one of those policy changes that has been slow but might be kind of increasing in the next few years.
Fingers crossed. I'm hopeful. I'm going to go ahead and move us forward and just kind of bring this back to the group. So we've had a really kind of helpful overview of co-occurring disorder and some of the discussion items around what are the needs and how do we address those needs. But it certainly is an area where I know there's interest in building more capacity to meet the needs. And so this is where it's helpful for Heather and I to hear from you in terms of what more, what else will help you and your organization meet the needs around co-occurring disorder. And so Again, we are in the first year of a 5-year initiative to support the Pacific Southwest region, and more broadly, we have the national network of mental health technology transfer centers, and so input from the field about what types of resources, training, again, kind of professional development and learning opportunities are of interest with regards to co-occurring disorder will help us design those things so that they are accessible to you and to your teams. And so I'm going to open it up to see if there are recommendations after participating in today's session, what more or what else would be helpful for you all. We had a couple of ideas of what things could look like. Again, we've had several requests around development of resources and training opportunities for co-occurring disorder, and both the mental health workforce and the substance use disorder treatment workforce who are navigating the needs of this population. So one idea that we had is potentially putting together a community of practice, sometimes known as a professional learning community, where a group of people, of professionals who are interested in this topic and want to kind of develop a cohort for peer learning purposes could come together on a regular basis. And so I will put that out as kind of one of the examples that we had considered. The other kind of examples of additional resources that we could provide were around a showcase of the currently available toolkits, assessment tools, online or other learning opportunities, all related to co-occurring disorder. And then finally, we have been in kind of early stages of consideration for a training curriculum that would be available to the region if agencies or kind of larger organizations wanted to do professional development training on co-occurring disorder, that we would have those available. So those are just some of our ideas, but again, we're really in a position to be responsive to the field in terms of the topics and modalities that are going to be most meaningful for you. We also have a needs query on our website and in our newsletter if you'd like to share your input that way, and then you could always just get in touch with us directly. But before we wrap up, I did just want to spend a few minutes to talk to you about why we're able to provide these services to you at no cost. I wanted to thank you, Heather, for being available today to talk to us about this topic. It's really helpful to have your context and your perspective. So thank you so much for being here with us.
You're welcome.
And again, we are available and able to provide these no-cost services because we have SAMHSA funding to do this professional development and learning opportunities for the mental health workforce. In order to keep offering these services, we really want to get your input and your feedback. And so I wanted to just let you know, once we close out today, that there will be a very short feedback form that we're asking you to complete. And again, that helps us make sure that we're continuing to refine our services to be optimal for your needs. And it also helps us keep track of what services we're providing so we can demonstrate that and continue offering them at no cost. So please, 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 we've kind of budgeted a little bit of extra time in here today just so that you could take the few minutes to fill out the feedback form that's going to pop up on your screen when we close out here today. So again, it's really critical for us in our work, and so we would appreciate it if you would take the few minutes to complete that. But I want to thank all of you for your time today. We will have this session available as an archived webinar if folks would like to access it again or would like to share it with others. It will be posted on our website. But again, I want to thank Heather and I want to thank all of you for your interest in this topic, and we look forward to continuing to serve you at the Pacific Southwest Mental Health Technology Transfer Center. I hope you all have a good afternoon.